For today, we're going to just see pediatric application of FES. So that stands for Functional Electrical Stimulation. So for today's purpose, I am only going to tell you a little bit about history of this. What is fascinating that first of all, this was used in 15 AD by somebody called Sherban Largus. I may not pronounce his name properly, but that's how it is. He was from a court in Roman Emperor. And he did this to reduce, he did the stimulation to torpedo fish, try to get rid of the headache. That was the first time this phenomenon was used. Then there was no word of till 1600 about electricity. So then that was discovered. William Gilbert, an English physician, found the word Latin for electricos, which means basically something that it transfers or something that you rub against and you get electricity. In 1780, Luigi Galvani, so I don't know whether any of you are aware of this, because Luigi Galvani did the first nerve electrical stimulation. And when I trained all those many years ago, we used to use this technique. We used to put electrical stimulation, or not electrical, these pads of metallic things in the water and get impulses going. Very uncomfortable. But that's what we used to do when days gone by, long time ago. And then finally, Moe and Post patent functional electrical stimulation name. So as you can see, it's been a long time, 1967. So this is not new concept. And I don't know, at this stage, I should know how many of you have done this, how many of you not been doing any of it, never heard of it, or were nervous about it. But we're just gonna have some introduction. So why are we using it and how effective it is? So there are many forms of it, of neuromuscular electrical stimulation. The device at the moment we're using, because it is cheaper in the market and it is 4-channel stimulator and parents can buy it, is called Axion Steam Pro X9. And this is widely available. You can even buy it in Amazon. It's just a device that, because it is 4-channel, we use it. It's nothing special about it. And also the other important thing is this: you can change the parameters, you can change the pulse, you can change the time, you can have it alternative, or you can have it in continuous treatment. So you can just play with it a lot more. There are other devices and they're equally good. So there is Sabo, most of you may be familiar. It's a 2-channel stimulator. Sabo has got another 2-channel stimulator, which it does EMG. That's equally good. Cycling is another form of FES. In fact, that is FES, is functional electrical stimulation. And Neuro is also another device that you could use. And we've also used that here in the center. And the advantage of it is that you can pre-program it before, and you can then run the program, and you don't have to constantly change. So that's the advantage of that machine. And you can also use it, it's 4-channel stimulator, so you can use it for all the activities you want. So you've got Oddstock Company, which is an NHS, and they supply with they supply this in an NHS, and you've got a stimulation in the sole of the shoes. You could put that, and then you've got the wires that is attached. You can now, it's 2-channel, and you can stimulate dorsiflexion and maybe gluteus maximus on opposite leg, or you could do calf, or you could do hamstring. So it all depends what patients you assess and how their needs are. You can have Walk8, is an American device. It is a little bit cumbersome. You can see it's a bit bulky. So some people like it, and you can put that around below the knee, and its stimulate is wireless. The wireless ones, the advantage of it is that you could do all sort of activity. You can walk, you can go, everything's under your trousers. But most ladies complain because if you're wearing a tight trousers, it is uncomfortable and it sticks out, and some people don't like it, but it is available. MyGate, unfortunately, it was one of the devices that I really liked very much. The advantage was that it was two-channel, and that you could use one to stimulate the drop foot, and the other channel you could use for opposite quadriceps or opposite glutes, or whichever point that you thought gait is necessary, and you could time it. It was a very good device. It was about £5,000, rather expensive, but people bought it. Unfortunately, the company went bust, and or they didn't manage to sell enough in UK. It's a German made. We now got Bioness in the market, and there is a physio function sells them, and it's got now a device that you can put below the knee for the ankle for dorsiflexion, and you've also got a device that you can put around the thigh, and it's for quadriceps, for glutes, and no, sorry, what am I talking about? For quadriceps and hamstring. It's a good device, but it is expensive, and again, it's two-channel. So, but it is a good device for gait training. So the aim of this talk to actually be clear about technology, the names that we use, and at this particular one, I just want to talk about NMES, which is neuromuscular electrical stimulation, rather than a FES, which is everybody knows. FES is basically functional, that you put it around your ankle, or you use bike. So I'm going to talk about neuromuscular electrical stimulation. So the key difference in the children and adult is that children don't get as much fatigue. So their muscle fibers composition is different to adults. They've got a different metabolism, and the motor unit activation is also different to adults. So for the purpose of FES, is that basically what it means that we can actually stimulate the muscles and put amplitude much higher than you anticipate, because most people are nervous. They think, oh my God, is a child, they cannot tolerate, but they can tolerate, and they get much longer and they get less fatigue training them, because it's type 1 muscle, so they need a lot of work to be done. Metabolism, it's the amount of energy they burn out. So it's also, they respond better in this situation when you can apply more stimulation. You don't get the fatigue that you get with adults. Motor unit activation. So they did this study on 10 participants with some diplegics, cerebral palsy, some hemiplegic cerebral palsies, and they did also compare it with normal. And they found that actually cerebral palsy kids, the muscles are really weak. They don't recruit enough muscle fibers. And that's to get proper action. So the action that you really need, they've got the muscle, they get the firing coming, they can recruit the muscle, but it's not enough. So they often have knee flexion, and they cannot fully extend the knee. But you can isolate the knee extension, but they cannot do it in the walking pattern. And this is what they found from it. So how does FES work? It's basically you stimulating the nerve that it enters into the muscle belly and makes the muscle contract. You can apply it in a variety of conditions, but you need to apply enough to get muscle contraction. So that's quite important to get the muscle contraction. So your parameters and your pulses and your frequencies you use is got to be enough to get muscle contraction. And this is the base of the FES. So when you get the muscle contraction, it then sends the signals through spinothalamic tract into dorsal ganglion, from dorsal ganglion into the motor aspect of the brain. So it has a wide range of effect. So the muscle becomes contracted. Once the muscle has become contracted, you actually change the physiology of that muscle. You're also able to get better pattern of movement. So you can use it with the stroke patients, you could use it in spinal cord patient, you could use it in cerebral palsy kids. You can now use it in muscular dystrophy. You can also now use it in spina bifida. Those two are new, and we can discuss that much later. So what happens actually? What is interesting is that when you stimulate in the muscle, it will when the axon gets artificially stimulated, it has to get to a certain point, and that point is called action potential. And that process, it means that the sodium channel and potassium channel that they change their, so the sodium channel is in just there, and these sodium channels open up, pass the information through with the glutamate, they get attached to another thing, they open up the channel here. This will then changes, the potassium becomes positive, this becomes negative, then impulses go along and the nerve becomes stimulated and it passes the contractions. And this process of polarization and depolarization is what makes the nerve fire on and stimulation to pass by. So this is really all jolly well and good. So you get optimal level of neural activity. You could get synapse. At the point of synapse, you get changes. You get myelination and new cell birth and neural cell survival. So these are the studies that Daniel Becker from Johns Hopkins University has done on what happens when they do FES. So his paper is really interesting to read. So what he says actually is that as you use the FES on a spinal injury or people who've lost a myelin sheath, you can see this is a myelin sheath loss here. Along the nerve fibers, there are stem cells, and these stem cells become inactive when the demyelination has happened because of the disease or the condition. So what happens when you get FES? These stem cells start generating new cells, oligodendral cells, and these oligodendral cells go into the brain and they make myelin sheath. So that is so exciting. This is really exciting that FES does this. So they hoping that they've done a study on the mice and they put an electrode on the back of the mice. They made the mice obviously paralyzed and then they put the device there after a few days and they stimulated and they could then measure it and see what happens. And what they saw is that the new cells were generated. You see these stem cells. So these glial cells are the ones that are reborn and they regenerate. And glial cells are also new cells that they're born in hippocampus and in all olfactory lobes. So once you get that, that's so exciting because you can then change the condition from demyelination into myelination. But obviously, you need to use this on a continuous basis twice a day to get this for half an hour each time. So the cells that they found that you get is these cells, the nestings, and these proteins. And these proteins are all make the oligodendron cells, and they actually migrate to corpus callosum in the brain. I find that very fascinating because what it means, then we can treat totally spinal injuries with FES, and hopefully we can get walking pattern. So that's the whole idea of FES. So that's when you've got demyelination. So when you actually don't have a demyelination, it strengthens the muscles, it works on the spasticity of the antagonist group of muscles, it reduces spasticity in the same group of muscles that you try to stimulate. It reduces co-contraction, increases central stimulation and motor activity in the brain. The difficulty is actually to say whether it's a peripheral change or it's a motor or a central change. But if you keep repeating it, they're actually, you definitely get peripheral all of this, and also you get plasticity. And plasticity is when we continuously repeat the same pattern and the brain relearns. And the learning happens in hippocampus and also send the signals to motor cortex. So you get a phenomenon that the whole brain starts working. But the trick from this plasticity to happen, it means repetition. And repetition, it means motivation. Motivation means that you really have to get the person wanting to do it and wanting to see the change. And there are many ways, obviously, as physios, we are expert at motivating people. And also the same token, we can off-put them. But it's to find a way, each person has a different way. So to get this repetition and to get these pathways and plasticity, I think is the key to our work. This is the way we need to go forward, finding what we're going to do, how we're going to do, how we can encourage this person to actually want to use the FES on a regular basis. With children, the way to introduce it is put a sticker, make it fun. Don't suddenly just apply. Use different types of stickers and encourage them to switch it on, switch it off, so they can actually learn to control some of the knobs. And once they do that, when they feel they're in control, they are not so scared. They're happy to practice it. So it's wanting them or making them wanting to do it. So we call it buzzer, we call it zapper, all sort of funny names that they like, and we can get good result from it. So what is it in the central nervous system? What central nervous system, when it is damaged, it is certainly motor aspect is one aspect that we all see. Sensory, we always talk about it as physios, but we leave it to other people to talk about it or assess it. We don't really assess the sensory any more than just hot and cold. Autonomic nervous system is obviously by your bowel and bladder. Again, is a topic that we're all embarrassed to talk about. But bowel and bladder is a big issue in a neurological disorder. In CPs, they are obviously not nappy trained for much longer, and all the other kids, they've got a lot of difficult time with the autonomic nervous system. Pain, I've not seen many kids complain of pain when they've got neurological disorder, but certainly adults have difficulty with pain. They could have banding, they would be one of the difficulty that they've got. They've got abnormal sensory, they would be sharp sensation, and they would be complaining. So if any person with any neurological disorder, doesn't matter what name the neurological disorder they've always got these difficulties. They've got motor, sensory, autonomic, and pain. And we need to assess it. We're very good to assess the motor, grade it. I've not recently bought something called that you can actually measure the motor fibers, how much muscle fibers are recruited. So that is rather exciting than go Ashford scale. But I like that better because I can measure it and see it. Sensory, it's a very interesting. With a clinical presentation, sorry, I jumped into the sensory because it's my bug bunny. Clinical presentation of motor aspect, obviously you get paraplegic, tetraplegic, upper limb, lower limb weakness. You can get tone changes and you can get flaccid. This is recently a big thing, how to improve a flaccid arm or low tone babies. This is quite difficult. So there are new machines coming that you could actually stimulate with the flaccid arm because you need to use the different types of electrode. But this talk, we're not going to talk about it. And obviously they all have increase in tone or decrease in tone. So these are the phenomena of motor aspect. The same token, you have poor pattern as well as you've got poor recruitment. And some of that obviously is posture. So clinical presentation of sensory is paresthesia. It's you get area of the brain, area of the body that you don't actually feel anything. You get numbness, which is slightly different to that. You get loss of temperature sensation, which we can all test as a physio. We also got loss of proprioception, and that is quite an important thing to test. It isn't just joint going up and down, it also affects your whole balance mechanism, depends on your proprioceptive system. And one of the things that you can change with FES is proprioception. So that needs to be tested. So I like to do sensory test, do sensory proprioception due to the lesion of dorsal column. Sensory loss of the face and the body is to do with the thalamus area. So you just need to, it's really tested. Sensory loss to peripheral neuropathy is brachioplexus. Sensory loss due to neurological finding in MS. And 90% of these patients have sensory loss. Loss of pain and temperature is also spinothalamic. So if you've got somebody says that I've got temperature problem, they can't feel the hot or cold, or they're actually affected by it. If the weather is too hot, they get low tone. If the weather is too cold, they get contracted. It is a spinothalamic tract that is affected. Tactile and sensory is also, it's important to test. So here I would test them with different types of brushes with a different texture to see whether they can actually distinguish between each texture. The graphitesia, it can also be tested. Strychnosis is really easy. We all know how to test that, but you can also make it fun for children and put the stuff that in a bag that it's more fun to do. See things that they are familiar with, you know, some rubber dolphin I found, and kids really loved that texture, so they could search for it and learn about it. So you could test that. Lesion of post-central gyrus or parietal lobe can cause contralateral sensory loss and strychnosis. So with the eyes shut, they cannot pick what it is. So. And impaired position sense, impaired tactile sensation greater than pain, temperature, vibration. So vibration is another test. I mean, though we can't test it, but if you use a tuning fork, you can actually see whether the child looks at it or not, doesn't look at it. So if you use a vibratory fork and put it on the knee or head, if the child doesn't look, you really know that they don't feel any vibratory. So if they don't feel any vibratory sense, they will not be able to extend the knee or the head. So that's quite important to test it. You could also get another vibratory fork to get on the muscles and ligaments, and if they look, you've got it. If they don't look, it obviously is absent. Oh, sorry. So sensation deficit, it also causes muscle wasting because they don't know how to recruit it. Body position, asymmetric body position alters the center of gravity. Poor anti-gravity muscles action and poor balance reactions are all parts that you can actually work to improve. Spatial awareness neglect is quite common in cerebral palsy kids, and that you can also work to improve it with the FES. You can work on a sensory aspect of it and to improve that. So when we're talking about parameters, it is frequency, is the number of times, actually I'll put it in definition, it refers to the number of stimulation of pulse delivered per second. So low frequency, you can get the muscle twitching. When it's contracted and short, if you use a low frequency, because you get the muscle tired, you can then stretch it a bit more. So I would use a frequency of 10 on a calf muscle that is really tight. Before I want to stimulate T-band, I would use it on that muscle and the hamstrings because those two are really tight. because you constantly stretch to go back again. But what you need to do, change the physiology of the muscle and get them more fibers to be recruited. So stimulation on 10 is sharp twitching. They don't even mind it. It's quite interesting. They don't mind it at all. So that you can change contractions and deformity with that. The medium 20 hertz, it creates a tetanic muscle contraction and it improves joint range. I also use the 20 hertz, between 20 hertz to 60 hertz, but 20 hertz specifically is used in Molly suit, which is you can wear it every day for 1 hour, and they've got electrode all over the Molly suit. And the interesting thing is, over a period of time, you see the tone is reduced. So it reduces the tone. If you use a neuromuscular stimulation device on 20 hertz, you get some sort of like a pins and needle feeling, and they actually start looking at the part of the body that they've ignored. And it's so good to see the child looking at the part and stop ignoring that affected part. So high frequency, it also creates tetanic contraction, but it's a bit uncomfortable. So I use between 20 to 30. I use normally 45 hertz to get muscle contraction. Pulse width it refers to the length of time that each stimulation it goes. So you can reduce it from 50 to 200 hertz. So I change the pulse width and the frequency together to get the length and the time that I want to get that muscle to contract. So medium, you get a strong contraction. So best contraction is around about 350 microsecond. You get. I've never used 500, but I think, that doesn't mean that just because I haven't used it, it doesn't work, but you can get very powerful contraction with that. But I just used the 354 to get a good contraction. And for a small hand, sometimes I use 200 pulse width and then use 35 frequency to get good movement. So amplitude, it all depends on the child, how much the child tolerates. Invariably, they tolerate it really well and they don't have any difficulty. If you use a low amplitude, you don't get much reaction. So you really need to play with that to find the right amount that you get decent, good contraction and the child is happy. So those are your amplitude. So I'm going to talk about this child who had very poor proprioceptive and very poor awareness of her body. She had very angry child, very angry. She didn't allow me to even touch. So it took me ages before she would actually allow me to put FES. You can see her position is completely onto the lateral side, lateral border, and she would walk like this. So ended up having, sadly, surgery, but because they couldn't afford to come on a regular basis, so it got tighter and tighter, and they eventually had operation. But nonetheless, I started using her T-band to stimulate it, to just get the foot in a better position. And you see, I could just get it flat for her. But she just didn't have just that problem. She had, this is a walking pattern. Let me see what this is.
Straight ahead.
You see how she's walking?
Much side to side. Yeah, but that is because we're not feeling that leg. And
So she's just not using it at all.
So you really need to go back to the thing.
So the most interesting thing is,
I come with you.
Oh, I can't reduce the sound here. Most interesting to see how she's using her eyes to transfer her weight. And that's the problem. You see, she's trying to look at the screen. Do you see what she does? And that's why she's not actually able to weight transfer. Because the difficulty is actually she's got difficulty with her oculomotor skills. See how much she's trying to move to see the screen. Now, if you see a child like this, you really do need to refer, before you analyze anything else on their walking pattern, you need to send them to behavior optometrists to sort out the oculomotor skills, because of this lack, she's not ever going to use her affected sight. So we could also improve static balance. Static balance, though we think about is that the person just is standing, but it's not just the standing. In just pure standing, a lot of stuff is happening. You need to be able to transfer your weight back onto your heel. You need to have a good awareness of where your body is in space. You need to be able to have a good posture, means that you can get good alignment of the muscle and you get the muscles to start firing. So it really needs posture, really needs vision, needs vestibular system, needs cerebellum to function, to get good posture. It isn't just the muscle fibers. So though we need to have a knowledge of what the posture is coming from, we also need to understand which muscle group we want to stimulate. And that static posture is equally important to stimulate and achieve, as well as a dynamic posture. So this is a young lady who's got, as you can see, massive lordosis and quite a lot of retraction of the hip on the right side. And you can see her head alignment is abnormal. So when the head alignment is abnormal, it tells me that she's not going to weight transfer equally and effectively. And she does then obviously has a funny gait. But as much as the moment I look at this, I also look about her oculomotor skills. And she had a very strong strabismus, which means the eyes are not aligned. And as a result, she would tilt in a way to get her body move. In order to see, she would tilt her head, and to tilt her head so she would be different weight bearing. So to improve her static balance, I was stimulating. So ramp means you can get a different types of ramp. Ramp 2 is just slowly going up to get the muscle contraction. So I was getting 15 seconds to contract and 15 seconds to relax. Pulse I was using 350 and frequency 45. And I was stimulating her calf muscles, buttocks, and her T-band all together, so I could get her weight back onto the heel. You can see from the sponge balance that she's standing, she's actually digging in a bit more here onto the heel. Because it's a little bit boring with the static balance, I also use balls or any other games that you could do so you can actually get more dynamic activity. This is another way of getting the balance activity working. So I'm using the FES on the same sort of parameters on this young boy, and I'm throwing a ball at him and he's sitting in a cone that he's got to get movement of dorsiflexion. You can see nice dorsiflexion on unaffected side, and I'm trying to achieve the same on his affected side. Just a tiny bit I managed to get dorsiflexion. So you can make a game to improve the balance. It doesn't have to be just I push you. You can use a variety of stuff. So he's sitting in a cone and also sitting on an air cushion. I don't know whether any of you are using an air cushion. It's the way to learn equilibrium reaction of a trunk and a head righting reaction. It's superb for that. So it's stimulating all aspects of the child while he's having FES. He's also got, you can see he's got a good his unaffected hand is perfectly, he's using, but he's also able to use his affected arm quite nicely to reach. So there is lots of evidence to say that FES works for the balance reactions. And there are papers with the static balance is done by different people. You could always see these. And they more or less use 200 hertz, 30 hertz and 200 microsecond. And the amplitude is whatever chart tries. They've done it in different positions. And conclusion is that the children do improve with this balance reaction and FES. So this is a child with total sensory loss and total neglect, and had great difficulty with sensation and also other complication with the eyes. So here you can see I use a tiny electrode, the 2 centimeter electrodes, and I put a sticker on. I don't know whether this is a film or this is a film. No, none of them is a film. So I use it to get the extension because he was very clenched. So here I'm using it when he's sitting in a cone, trying to get protective arm support sideways, but he's really tight and pulling it up. So I've used it on his triceps and his wrists. He didn't want to take it off and show it, and on his trunk extensors. So here he's sitting on a peanut cushions, and with his affected hand he's holding a drum. Oh, I keep doing that. I keep thinking it's a film. And he's really happy because he's actually using, after he's done the whole session of FES, he was able to hold his very light drum rattle, and he was playing the drum and he loved it. So you can actually do something else afterwards with them or during the time they're having it. But while he was having it, he wouldn't let me do any other things. So we waited till he was ready after the session, and this what happened at the end of the session. You can see how tight he was here. Oh, I keep thinking I've got a film of him. Okay, so you can see after he's had his FES, his hand, he can put it on the table. He's holding it, holding an object, and I'm making him try to use both sides. And you see the head tilt? That means poor visual skills, poor oculomotor. They always got a head tilt. So once it's actually better, head becomes in the middle. So midline orientation, it works with FES. So here he's got the drum, and he is really happy to just even hold the cylinder in his hand. I was quite chuffed with that. And I've unfortunately had to block him, but he's looking at his hand. I mean, that to me, I was in seventh heaven. So you saw this girl earlier on that had difficulty with balance. Here I'm actually working to get her to do wrist extension because it was really poor. So I've used 250 microsecond, ramp up to 5 second on, 5 second off, and 35 hertz. And prior to 35 hertz, I've used 200 hertz to get her to look because she wasn't also looking, and she's happy to use the right hand more than the left. So just to get sensory first and then get action. And finally, she was able to do the cubes. I'm just a bit there. This is a film. It's still not full dorsiflexion, but better pattern. Okay, so now we're going to get into the next section. I don't know how we're doing with the time, or does anybody want to ask any question? Are we ready for question, or shall I go on to the next section? Okay, as I'm not hearing anything from anybody, I will go for the inflammatory. So cerebral palsy is, you're all very familiar, but acute inflammatory disorders of the spinal cord, which you can get motor sensory dysfunction, autonomous dysfunction, they can be monophasic, they can be monofocal. So these are also part of the type of people you get. So here in the center, we get quite a lot of kids with transverse myelitis. It is a rare disorder. I became interested in it in some years back, and we get kids coming from, I would say, quite a lot of UK anyhow for assessment, and then we train them to use FES, and they go back and then they come back. So they can be from anywhere in UK they come. This particular child had a transverse myelitis at a higher level, at T level, and he was totally paralyzed below. I can say that I still see him, and he has achieved tremendously. He can now walk with two poles to school. He goes to high school, and he's done very good result. And part of the work that Daniel Becker has done, he said myelination can happen, and certainly I have seen in this child the myelination has happened. He's now got active dorsiflexion, as well as selective knee control, as well as posture. He had no sense at all. He could not stand up. So you can't see, but he's got electrode on his buttock, on his hamstring, on his calf, and on his back extensors, because he had a massive lordosis and a lot of sensory loss. So these kids have sensory loss. They have no idea where the body is. And we use this in a weight bearing. And you can see here, I'm also using balance mat. He's a very clever young man, and so he always wanted to do puzzles, and that's the best way. He could do the puzzle while he's standing on a balance mat, and I could give him the pieces in according to where I wanted him to move. So this is his posture. You can see he's got no control. He didn't have any abdominal, so he was extended. I've used weight as well to improve his sensation and his awareness of weight bearing, because his legs would be floating. I don't know how many of you have seen that. So he had transverse myelitis 216. I should put a new video of him, because he's now, he stood on a beam this week by himself without a stick. So that much balance has improved. So functional electrical stimulation, he has at home his 2-channel stimulator. So he uses, this is the rate he uses it, and is successful. So when he comes here, we use 4-channel, but at home he's got that 2-channel stimulator. I'm going to stop now so you can have question and answer, because this is a new paper.
So what age do you find you can stimulate a muscle? For instance, supinators, which have never been used functionally or have been overridden by spastic muscles?
I would, the age doesn't really matter. You can start from 6 months upwards, as the child tolerates it. It's just, the question is, when you've got a small baby, you need to use a very tiny electrodes. So the tiny electrodes are a bit difficult to hold on a child, but you can use 2-centimeter electrode on a 6-month-old baby. The age does not matter. And when you get a supinator that's tight, you need to first reduce you need to reduce the tightness, do on a small 10 hertz on a palm aspect to reduce the flexion, because it's obviously flexion. So first reduce the flexion, and then work on flexion extension to get flexors and extensors to get movement going, and then do extensors and supinators. You can get the movement.
So as part of the same question, they were asking if there's a time when muscles are just too atrophied or underdeveloped to stimulate. So is there a point where, you know, basically a muscle is beyond hope in a way? Like,
Hopefully we don't get to that point, but if it gets to that point, you can start a point. You need to start at a point. When if the child is really atrophied, you can start on a different frequency. So the problem is when it's atrophied, you need to use a different types of electrode to get so that it's not uncomfortable to put the stimulation. And those kind of electrode are sponge electrode. You need to have a different machines, because the normal NMES that I just suggested, it will not tolerate that. So you need a different types of machine. Neurotrack will do that, for instance. You have different electrode. If you use a different electrode, you can then slowly build it up. So the electrode is a sponge, and you put the pad inside. It's padded. So you put the electrode inside the padded glove things. Unfortunately, they are a big size. They do not have the small baby ones, but you can do it as maybe 3-4 years old because the size of it is big. You don't have that tiny size. If you cut them, you don't get the same effect. So you really need to have right size, and they don't make it small. So for pure atrophy, I would just do on a very, I would use maybe 350 hertz and 20 hertz for sensory fast for a period of time. So when the sensation is improved, you can then build up the motor aspect.
okay. So then the next most popular question is, how long does the effect of the electrical stimulation last?
So all the studies they've done, you need to do it for 6 weeks on a continuous basis, every day, 20 minutes, maybe twice a day if you're really very good. If you do that, effect lasts long time, long time. But you need to do it every day for 6 weeks. And that is the trick. To motivate the child to do it every day is the trick. So once you able to achieve that, if you've done it 6 weeks, you get nice calf muscles, you can get very nice standing balance, you can get very nice hand function. You saw this other young lady that I had, and she was motivated. They bought the machine. She very expensive machine, Stewell, that unfortunately again is not in the market. It was a 4-channel stimulator. She used it and she got very good hand function. That was her hand function. From nothing, she would drop everything. She couldn't use it. So
How long do these effects seem to last in your
while
experience?
she used the machine, I would say over a year, every day, and now she's got full hand functions. She doesn't need to use the stimulation.
Okay, so she's used it for a year. Okay, and then she maintained the results.
Yeah.
Okay. How long after she stopped it using?
She stopped it, I think maybe 6 months ago, 7 months ago.
And she still maintained the.
Yeah, hand function is fine.
Okay. So the next question is, does the muscle type changes in CP limit the time FES is effective? So we're talking about CP muscle fibers kind of being different from normal muscle fibers.
Yes, I mean, they are different because they are not recruited. They are not recruiting the same level. So you can actually change it with FES. If you do it every day,
Yeah.
and parents are committed to do it every day, you can change the physiology of the muscle. It can remain the length can be maintained, joint range can be improved, spasticity can be reduced. So it's really is to use it, is to use it every day.
Okay, so it's more in the how much you use it rather than.
It is. You really have to do 20 minutes every day for 6 weeks, then you see the result. And then you have to maintain it because the child, as they grow, muscle becomes shorter. So you need to then keep stimulating to maintain that range of movement. And also keep doing other things because the pattern of movement is also crucial. You need to do lots of activity of normal development to maintain the range of movements and the activity appropriate to their age group.
Okay. This next question also is quite interesting. Is how long do you tend to keep the unit on before doing functional work? For instance, 30 minutes.
That's
Do you keep it on while working on function?
That's very interesting
Yeah.
question. Whoever sent it, thank you very much, because it
Yeah.
needs to be goal directed. It needs to be while you're stimulating, you need to be able to do activity with it.
Yeah.
So if it's no point to just stimulating and watching television, you need to do activation with it. It needs to be goal directed. But by that I mean, if you are going to use hand function, you need to work on grasp, power grasp, pincer grasp. You need to do with the same pattern of movement. So if you're going to do reaching, it needs to be able to open up, hold, use the flexors to hold it and position it. So this got to be a pattern you're going to practice. You got to practice this pattern with the FES.
In a
Once
function.
you've got the FES, once you've got the NMES on, once you've done it for 20 minutes, done, then practice it without it. And then if you've got still tightness, go back to NMES and do it again till you get this activity going. And while you've got it on, it should be always goal directed, always should be goal directed, always should be functional. It always should be something they do with it rather than nothing.
Okay, but I know I'm aware that earlier you mentioned about obviously sometimes, you know, waking up the sensation first. So maybe working on sensation and range before you do the actual functional activity. So how long would you do that for before you start with?
If the child that you saw earlier, the hand is really tight and deviated like this, so I would do 20 minutes to just allow him to be able to have freedom in his range of movements. Once he had the freedom and I could move away from him, then I would do maybe another 10 minutes to get motor activity.
Okay,
So
fine.
maybe first I would do a lot more sensory, then I would do motor.
Okay, so about 20 minutes is a good time you find to adapt to the
And
sensation.
you will see it with the child. Maybe 20 minutes is too long. Maybe you should just do 10 minutes. But
Yeah.
it's just something you have to constantly visually
So
see.
reassess. So what you're saying is to always try and then kind of
Yeah.
reassess in a functional
As
context.
you go, as you go. But it always has to be goal directed. Always got to be something holding, something doing. You see,
Okay.
sometimes for the purpose of photograph, you can't get the action the same time. So you have to put the FES down, give something else, and then take a photograph because you miss it. But that particular child was always holding the uh, the small little bar in his palm of his hand so that I could get him to like the sensation of holding,
Okay.
of having something
Something in his hand.
and slowly looking at it.
Okay, so the next question is, you mentioned muscular dystrophy. Which conditions do you use these on?
Oh, that's interesting because that's a new paper.
Yeah.
We didn't ever use FES on the muscular dystrophy, but we can now. And so there is, I think I'd just like to put it for the next one rather than discuss it now, because it is very interesting that we can do it on a muscular dystrophy, because up to now, nobody would use on anterior horn cell disorders.
So from the papers that have come out, are they mainly on kind of bladder?
No, on all the on the calf muscles.
Oh, okay.
This is done a lot of studies on the calf muscles, and they found that they, instead of getting all very woody and rigid, they actually managed to improve the bulk of it and improve the strength of the calf muscles. And the same token managed to maintain walking for much longer in the muscular dystrophy.
Okay. And did they mention what conditions they in the paper they tried it on?
I can't remember details of the paper.
Okay, but you've added the details in your reading list, so people will be able to access it. So the next question is, what is the youngest age that you have used FES with?
I've used a year, from a year old.
From a year old. Okay.
Yeah.
What did you work on with that baby?
So the child had very, very tight calf muscles. And so worked on the calf. It wasn't just the cerebral palsy, it had also some genetic disorder which made the muscles very tight, and I can't remember the name of the muscle condition, the genetic disorder he had. So he had genetic disorder plus cerebral palsy. So it was very peculiar muscle. And it was a year old, totally plantarflexed already. So I managed to just use it on 10 hertz to actually get muscle to relax, managed to get range of movement, but it took me good over a year to achieve that.
Okay, thank you. The next question is, can you use FES with children who have a shunt?
Yes, you can.
Okay.
So the only contraindication for FES, and that is, it can also be clarified. If the child has got repeated epileptic fit, you need to discuss that with the neurologist to see whether they will agree. That's only one contraindication. They say don't do it, but they've never done any specific study to say FES created the epileptic, but it can do. So it's the best thing is to speak to the pediatric neurologist and get agreement from them. That's one. The second one, if the child has got stents or heart condition and they've got mitral valve, so you don't want to have the different frequency with them. And again, if you speak to cardiologist who's done the surgery, invariably they will give you the yes to do FES. So, but you need to, if these two conditions, you need to discuss it with the neurologist to clarify that it's okay to do it.
I'm aware we've got a few more questions left, and we have probably just about 5 minutes left. So the next question is about, have you ever used FES with children with obstetric brachial plexus?
With?
Obstetric brachial plexus injury?
I don't see many, so I have very little experience.
I don't see why not.
Yeah, I don't see why not, but I certainly don't get them to come here. I don't get them, so I don't know how effective it would be, but I am sure if you Google it, there is somebody's done it somewhere. So I personally don't have the experience.
Okay. So the next question is about, from Anna Wright, she was asking how many sessions did you do with the last child? I don't know if it was the child that you did the reaching work with.
Which was that?
The last child that you showed in your slides, but I can't quite remember. I don't know if it was.
Is this guy with the transverse myelitis, or this girl?
Do you are you able to share?
Let me share
screen again so we can make sure that that's the right one that she was asking about.
Is this the person?
Deidre, would you be able to maybe unmute Anna Wright, if you're able to see if she can tell us if this is the child she was asking about?
Anna, would you like to clarify which child you're talking about?
Yeah, I was just talking about the last one. To be honest, it doesn't really matter which one, but it was the last one where you saw quite a lot of improvement. I was just wondering roughly how many sessions you did, but you've kind of answered it in your 6 weeks of 20 minutes a day.
Yeah.
I was wondering how many sessions you actually did with the child in that 6 weeks.
She comes to me, she used to come to me twice a week. So I did it twice a week when she came here. She also had the machine herself, so she used it at home. So she used it every day.
Thank you.
Okay, thank you. Fashida, can I also ask you how many sessions do you find that you need to get the parents, at least the parents, kind of up and running with the easiest form of FES?
It depends on the parent.
It depends on the child, but do you find that generally to make sure that they understand? I don't know.
It depends on the personality of parents and how keen they are to use it. This particular one, she actually learned it better than her parents, to be honest with you. The machine she has is a Stewall, which is complicated machine. It's got all sorts of things. She cottoned onto it in third session. So she's an intelligent girl. She is, so in third session, she was fine. So let's say if we have cognitive problem. If you have cognitive problem and you can't be learning any of this and your parents have to do it, again, it depends how quick, how they want to do it.
Yeah.
If the child doesn't necessarily play them up, because, you know, obviously some kids play their parents up terribly. And so if the parents feel nervous, the child instantly picks it up that the child, you know, this is, oh, my mother doesn't like to do it. They play up and they never do it.
Mm.
So it's something that you need to suss out on the parents and the child. So now, as Zoom, I've been teaching it to parents on Zoom.
Okay.
And people pick it up because they're keen to do, because they feel now they're left out.
Okay. Have you managed to teach it on Zoom even though you'd never kind of had a face-to-face session with them?
Yes, I have managed to do that, yeah.
So the last question,
I must know the child. I think I know the child.
Yeah.
So I can then teach them how to use it on Zoom. But I know the child and I know the weakness and I know the difficulty they've got. So if I don't know the child, as an interesting question, for the first time, I saw a child on Zoom, and I've never had anybody to assess on Zoom from the start. So I assessed this child, and it was a very strong hemi, as in didn't want to use the hand, but had function to use it, but didn't want to use it. And I suggested FES to parents. So it'd be interesting to see whether I can actually do it. It's something that, you know, I'm learning to do on Zoom with people. I know that people learn, and a simple device is really easy to do. You can just exactly run them as you go along, and they are very good to write it. And then these days is really good because instantly they take a picture. You can share which muscle you're going to do and how it looks and what actions you want to get. So it is easy to do on Zoom.
Great, thank you. The last question is about what type of current you use with children. Is it pulse electric stimulation or continuous?
So if I want to get a standing posture, I would use it on simultaneously so I can get all the muscle fibers working together. If I want to get alternative action, flexion, extension, I would use it obviously on alternative current. So one group comes, switches off, and the next group comes. If I want to use it continuously, for instance, if I want to use, I want to get the child standing on a balance mat and the calf muscle is not doing anything, I can continuously stimulate it and throw a ball at them. So it just depends what activity you want to use. So if I want the child to really stand and shift the weight back onto the heel and the calf is really poor and buttock is poor, so I can use it on a continuous, so it continuously stimulates, shifts the weight back. They can stay there while they're experiencing other movements.
Okay. The last question is about from Sally. She's asking if you're using FES for gait re-education, would that also be for 20 minutes twice daily? If you're working on gait?
Gait. So the difficulty with gait is that the neuromuscular electrical stimulation device you use, the timing of this is not right. So it's really hard to use that particular machine to get gait, unfortunately. Timing of it, it's really difficult. With a better quality machine like Stevel, which you could time it, you could then work with it. Again, I would do it every day rather than twice a week because I would use twice a week here, but parents would have it at home. Finding a device, and right now I don't have any, except the Bioness, we don't have anything else for gait because it needs to be wireless because the wires get on the way. The timing of the Bioness is actually, you can organize it with the type of walking you want to get. When you've got an MES, you cannot stimulate it unless you switch it on off like NeuroTrack. So you can have a 2-device NeuroTrack to stimulate one leg and stimulate the other leg. So you can do that, but to be honest, it's got hard work. So I find it very hard to do the gait itself. I can only just do one step forward, one step back because of the wires. And I don't have wireless here now, except the MyGate. And MyGate or even Bioness are not small enough for kids. So the cuff is too big for the kids. So we don't have any device. I think Bioness in America, they're using it on a 6 or 7 years old upwards. I've not seen a small cough.
Okay. Have you heard of the E-step? Because I've heard that the E-step, I think is from DMR.
E-step, I have heard of it, but I've not.
Like sock, I think it's used with a Lycra sock, perhaps.
I've not seen it in use. I haven't used it. But if anybody else is in the participant uses, send an email and share it with me, and I'm happy to learn.
Okay, great. Well, thank you very much. I think we've come to the end of the Q&A. Thank you very much for joining us tonight, for everybody making the time. Just to remind everybody, we'll be sharing the slides of the presentation and the recording of the webinar as well. And we will just notify people when this is available for people to access. And yeah, well, have a lovely evening, everybody.
Can I say something?
Of course.
So I'd like to thank everybody participating in this. And I hope you just had a tiny learning that it's okay, it's a good device, and that you can use it and learn to see what you can get from it. And if you get anything new, please pass the information to me. I'm happy to learn. It's a good device, and it's nothing to be fearful about it. There are lots of papers, and I've shared a lot of the papers with you, and you could all look. And around the country, everybody is now, around the world, everybody's writing papers on it. So it's there's a lot of researches going on. Please just try it. This is just the sample to say it's a good device. You could use it, and you can get reaction with transient mild autoimmunity disorder. You can even start bowel and bladder. It's something we could all learn where to put the electrode and how to use it. There's a lady in Oddstock called Tamsin. She's done a research on bowel and bladder in adults. So bowel and bladder will become muscular dystrophy is another, and spina bifida is all new. So please just, if anything you get that it's okay to use it, I'm happy with this. And up we go with the next stage.
Great.
I hope that makes sense to everybody and everybody's happy and they've learned something.
Thank you. I think there's definitely some interest from people to do maybe a practical like application session, but we'll see again from people's feedback. Whatever feedback we get, we'll obviously let you know, and we'll take into account for future webinars or training.
Yeah.